Absolutely. So one of the things we have in myeloma is we have tons and tons of trials, and we have a lot of trials that are 3 drugs versus 2 drugs, or 4 drugs versus 3 drugs. We don't have a lot of 3 versus 3. And we've been struggling for years about how to kind of wrap this all together and make it an even playing ground. And one of the things that's come along is this idea of MAIC, matched adjusted indirect comparisons. And we're trying to do this across trials to get a better insight into optimizing therapy in the relapse setting. So this one looked at Isatuximab versus Dara-Rd, and the short answer is that Isatuximab seems to outperform it. But one of the things that I think we've learned from this study is in the early relapse, where in the US most patients are either CD38 naive or CD38 sensitive, a CD38 based therapy is key early on. The question is, what do you combine it with? An IMiD, like lenalidomide or pomalidomide, or a proteasome inhibitor like bortezomib or carfilzomib. And I think studies like IKEMA and CANDOR have really shown us, and again, hard to compare trial to trial, but some of the best data is when you use an anti-CD38 plus Kyprolis. So for those really hard aggressors with extramedullary disease, high risk, the people that you really worry about, whereas I think many patients will give something like a CD38 and pomalidomide, we're moving forward with an anti-CD38 plus Kyprolis because they're very high and durable response rates. And if you look at some of the recent IKEMA data, these people are getting around 40 months progression-free survival for an early relapse study that's not a T-cell engager. That's pretty amazing.